Hi, this is Dr. Russ. Today we had the opportunity to work with a patient who recently strained her gluteus muscle, and there seemed to be some instability of the sacroiliac joint underlying the issue. We hope you enjoy the video and learn from it, and thanks for watching. Hi, it's Dr. Russ. Today we're here talking to Kat, and Kat hurt her back yesterday at the gym. Can you tell us a little bit about what happened?
Yes. So I was doing some free weights in a kind of a butt against the wall, come forward, and had two kettlebells going up and down, working on quads and hamstrings.
Okay.
And I very suddenly felt a strain that had a little bit of a pop feeling to it in my right hip.
Okay.
Which is unusual for me. Usually I get warning. My body gives me warning of a strain that I can then just back off.
Right.
I do not push through those.
Okay.
This one happened very suddenly.
Okay.
And immediately I was like, whoa, something happened, dropped the weights. I could feel that there had been a strain.
Okay.
So that was...
Good job, by the way.
Thank you.
Yeah.
That was yesterday.
Okay.
It has not gotten worse. I didn't wake up with it worse. That's good.
Very good.
I've been on infrared heating pad with a lot of prophylactic ibuprofen going. But I can feel sort of round the back from my hip and into kind of sacral area. Something in there pulled and is inflamed.
Okay. And is there any pain going down your leg?
No.
Okay. Does it hurt more to cough? Or
yes.
It hurts to cough?
Yes.
Okay. Does it increase only the lower back pain to cough, or does that create leg or foot pain?
Nothing creates the leg pain.
Okay. Why don't you stand up, face the window, and show us right where it hurts.
It was more on the side where the pain it's still tender there, but where it really became tender was more in here.
Okay.
So kind of in between my two fingers is where the strain happened.
Okay. So that's your glute max muscle.
Okay.
That's what that is.
Good.
Okay. Now I'm just going to have a look at you here, okay?
Okay.
And your arms are relaxed. Good. Good. Okay.
And I do have a pretty long history of unstable SI joint
on the right side. Okay. I'm going to bring this down a little bit, okay?
Okay.
Yeah, we can see you're a little bit swollen right there.
Yeah.
Yep. So we can see a little bit of puffiness here. Is this where it hurts?
Yes.
Good. As compared to this side. You have a little adhesive over here. What's that from?
That is post 5 year ago hysterectomy estradiol patch.
Oh, okay.
That I changed out.
Oh, I see. Thank you. Okay. Otherwise, there's nothing really catching my attention in your spine. No scoliosis. I want you to bend forward and reach for the floor. Really slow. You can bend your knees if you want. But let's just see what your body can do here.
That's pulling.
You pulling here? Okay.
Yeah.
Okay. But you got pretty good range of motion.
Yeah, it's not
tight.
grabbing. I just can feel the stretch where it was injured.
Okay, nice and slow. Come on up. Beautiful. Okay. So with this injury being new, we want to be careful. Even though it was 24 hours ago or so, we can't be really sure that we have seen the full manifestation of it. So we're going to treat this very cautiously and conservatively. The fact that it hurts a little more when you cough gives us pause that the swelling may be compressing a nerve in your lower back, and if that's happening, we want to make sure that we don't do anything to make that worse. And one of the ways I'm going to be able to see if you have any nerve tension is by having you just lift your right leg up.
Okay.
Go ahead and just lift it on up.
Just straight up?
Straight on up. And I'm going to assist you. And right to there, is there any pain in the leg?
No.
Is there pulling in your lower back?
No.
Okay, wonderful. So keeping this here, I want you to lift your head and look down at your feet. Does that create any pulling in your lower back?
No.
Good. Okay, you can go ahead and let that down. So that gives us a pretty good indication that the nerve root is moving pretty freely and is not being compressed. So that's a little bit of a green light for us to continue. So I think what we should do is just feel the painful area and see if we can identify which tissue is causing you problems. So go ahead and turn over. So we have Kat facing down, and I can feel the border of her sacrum. And here is her iliac crest right here, and the glute max fascia here between my fingers. I'm not using very much pressure because this is kind of acutely injured. Just want to sense if anything feels really disrupted, if any of the tissue feels particularly knotted, which it doesn't. But as I come down here a little more into the lower part of the glute and the piriformis, then I'm starting to feel some pretty significant trigger point activity. And I'm going to work that really gently. And checking in with you, Kat, are we okay?
I'm good.
Okay, good. So just kind of following that piriformis out to her greater trochanter, and I can feel that this right trochanter is rotated posteriorly a little bit. And I want to just really gently see what her hip can do, range of motion wise. And it's pretty good range of motion. Does it hurt as I pull it out, Kat?
No.
No, no pain there. I'm going to give your knee a little bit of a lift. How does that feel on your lower back?
That's fine.
Okay. And I can feel on her right SI as I lift a definite lack of extension here. And it feels to me like her sacrum has what we would say has come inferior on the right. And that's it right there. As I strum that tissue right there, Kat, how does that feel?
Tender.
Okay.
It's fine.
Is that the pain? Am I on it?
Of this injury?
Yeah.
No,
No.
I don't think so.
Okay.
I think it's farther out to the side, but I think what you're on is an area where there's regular instability
Okay.
in the sacrum.
So a little more of the
chronic.
the root problem.
Yeah.
Okay. So what we want to do is some gentle work here to take some of the swelling out of her glute first. And we want to really get a sense of the extent of this injury. And I think this injury is really mild. And I'm glad that you got right on it with heat and ibuprofen. So that was good. Coming up over her iliac crest, onto her QL. And we're just going to strip this muscle really gently. And it does feel like there's some tension in the lumbar spine on the right side as well. And we don't want to neglect her left side, so we're going to do a little work over there as well. Working from about S3 up to about T10. Just working these paraspinals. And Kat, you let me know if you need a break, okay?
Yep.
Good. So once we get this loosened up a little bit and we bring some of that congestion and stagnation out of the tissues, we're going to do some really gentle corrective work on her sacrum. Okay. So now we have a sense of the full extent, I think, of the injury. Doesn't appear to be any disc injury. There's no sciatic referral. There's negative straight leg raise. And definite pain with palpation in the lower SI ligaments, in the glute max fascia, and in the piriformis muscle. So those are the tissues we're going to focus on. And for now, I'm just focusing on her piriformis itself, working it from distal to proximal, from the trochanteric insertion into the lateral border of the sacrum. And we're not going to do any work on the anterior sacrum today. We're just going to focus on these external approaches. And we're going to be gentle. And we're going to remember that we're not going to fix this all in one visit. And Kat's pretty healthy. All we really need to do is get this moving and gently realign her SI joint. And the reason we're not going to use any thrust is she told us that the SI can feel a little unstable. And we don't want to get it more mobile. What we want to do is get those joint surfaces properly effaced because that is going to give it a lot more stability. So as I'm working her piriformis and her knee, I can feel the SI starting to settle into a better position, and we have better play now of the sacrum. And that inferiority of that right sacrum is starting to mobilize into a more appropriate superior position, which is really good. Now, it feels like Also, the tension is releasing a little bit from her lumbar spine, so I really think we're on the right track here. The next thing I'm going to do really gently is give some traction to her heel as I'm gently stroking across the fibers of the piriformis to try and induce a little more space in her hip joint and help her piriformis relax. Good. Good. So again, checking in with the joint play on the SI and checking in with rotation of the hip and the position of that right trochanter. And so far it feels pretty good. I like how this is going. So let's do a little bit of work on the left side as well. Even though the right side gives her more symptoms, we want to remember the pelvis is a bowl, and a bowl doesn't really have a right side and a left side. It's a circle. So our ideas of left and right are kind of arbitrary, and especially in the pelvis, how reliant the left side is on the right side function and the right side is on the left side function. We want to make sure we're doing both sides. So again, working the glute max, across the iliac crest. What I like to do for the QL insertions and this oblique abdominal insertion is pull. So I can get my fingers in front of it a little bit. And give it a little bit of a stretch. And can you give me a couple deep breaths, Kat? Good. And with this deep breath, I'm going to assess her rib mobility. Rib mobility depends a lot on those oblique, external oblique muscles and the QL muscle and their ability to relax. That allows the rib cage to expand. Feels pretty good. We're getting into some of her upper body stuff here. Some rhomboid and upper trap tension. And while we're here, let's just gently mobilize her scapula on either side. We're focused on the lower back, but again, these divisions are arbitrary, and there really is, the body doesn't know the difference between upper back and lower back. So there's a nice little trigger point in her right rhomboid muscle. Okay, nice deep breath, Kat. And let it out all the way. Beautiful. Let's do that again. Really nice. Good. And as I traction your lower back, does that create any pain for you?
No.
That's a really good sign. Glad to hear it. Let's try that on the left side. Feeling okay there?
Yep.
Great. Okay. So we've got Kat side lying. I'm supporting her knee, and I can make little circles with her hip. I do this not only to induce movement, but to make sure that she's giving me the weight of her leg. So I want the weight of her leg entirely in my hand. And I can feel the swivel of the femoroacetabular joint really, really nice. So I think her hip joint itself is in really good shape. But as I come into extension, there's quite a bit of resistance to that. And I can feel using my palpation skill that there's some resistance here in her rectus femoris, and there's some resistance here, up here in her iliacus and psoas. So she twitches a little bit. When I get my finger on the iliacus, that's not unusual at all. But what I want to do is see if I can work a little more extension into the system here. So as I'm working her into extension, I'm feeling where that resistance is coming from, and I'm using my other hand to gently work through that resistance, stretching the fascia. Remember, a lot of the resistance, a lot of times, is in the fascia and not in the muscle itself. So you might feel like you got to get in there really deep to get on the muscle and work the muscle, but sometimes you're working through the fascia and the problem is really much more in the fascia. So that's where we are right now with my right middle finger. I'm just on the edge of her iliacus, her QL, and where it meets the external oblique abdominal. And we're going to work that. Yeah, she's okay. You okay?
Yep.
And I just felt that let go nicely, and we just got about 5 more degrees of extension, which is great. So we're going to continue working along those lines. And I don't need to induce all the extension all at once. I just want to get as much as I can to get started with. So again, Kat, give me your knee. And we're working the lower portion of the psoas here. It's always really sensitive, and we don't want to be aggressive with that. But we do want to try and see if we can induce a little more extension. Is this comfortable in your lower back?
Mm-hmm.
Good. So you can see with my right hand, with my left hand, I'm giving a little bit of headward traction, opening up that gluteus medius, opening up her hip joint, as I am just asking her hip to extend a little bit more. And there we go. We got another couple of degrees.
Actually feels like a really nice stretch.
Good stretch. So nice deep breath. Make sure your knee is heavy for me and that you're not helping. Keep breathing. Good. And we're just going to chill here for about 20 seconds or so. Really well done. Good. Now I can feel some of the tension shifting laterally more into the area of what we call the IT band. So we're going to start to induce a little more adduction, internal rotation. Yep. Starting to get more stretch down the lateral line of her thigh. Good. Yeah. Going to finish this whole series off with some gentle fibular mobilization. As I'm everting and flexing and extending her ankle, I'm inducing movement of her fibula, because that fibula attaches to the IT band, and that IT band attaches right up to the iliac crest and the hip flexor. All those things function or dysfunction together. So we're working on a couple of different levels here. One is the more acute injury that happened yesterday, which I would say is a mild glute max strain. And then underlying that, and probably the root cause of that, is that sacral inferiority on the right, creating a little instability of the pelvis. So as she's bent forward with 40 pounds, 20 in each hand, that's a lot of leverage coming through the SI joint, and the glute max overworked a little bit trying to stabilize for her. And it's a good thing it did, because you'd rather slightly tear your gluteus maximus muscle than really tear your SI joint. Those ligaments would take a lot longer to heal. This up with a little more fascial work, coming a little bit more superior. So this is the thoracolumbar fascia overlying the latissimus and the QL. And I'm just really gently rolling it in my fingers, mobilizing it. Remember that most of what we're trying to do anytime we're doing body work is mobility and circulation. A lack of mobility leads to lack of circulation leads the tissues to dysfunction, and eventually over time degenerate, and that's really what we want to prevent. So I'm getting my thumbs and now my fingers kind of between the superficial fascia and the outer layer of muscle. You can see I'm giving it some stretch and rolling it a little bit. It's going to turn red. That's good, because we're going to get some blood in there. How's that sensation, Kat?
That's tender.
Is it too much?
No.
Okay, we're good to go.
I'm breathing.
Yep, you're doing great. But it's pretty darn stuck, and we really want to make sure she has good mobility through there. Using a little bit of shea butter to get a little more lubrication on the skin. What I would like to be able to see is, as I traction superiorly on her ilium, getting a little tiny bit of segmental side bending in each of her lumbar segments. And they're moving pretty well. So really the tension is mostly superficial, which is good. Can you bring this arm up over your head like this? Yep, that's going to elongate your lower body a little bit, and I want you to take some deep breaths into these lower right ribs here. Really good. Good. Doing great. Good. Okay, I've got the junction of ribs, I would say 9 through 10 and 11 here, and we're just going to get a little space. You keep breathing. Good job. Great. Thank you, Kat. I appreciate you being our subject today.